It's a pleasure to be here with you this evening, and I'm delighted that this is actually an integration of health technology and senior care, because I think that those two are extremely important points to integrate. And I just wanted to start off with a little story about when we first brought this whole concept up to the White House, the beginning of this administration. We had a meeting, we had a roundtable, which is out there on YouTube if you're ever interested in seeing it. And the conversation was around the patient-centered medical home and the name of it. And Nancy Ann said, you know, we really can't call this medical home because although it plays well in pediatrics, it plays well in the military to have a home-based medical home, it doesn't play so well with the senior population because they equate it with nursing home, Soylent Green tablets, right, et cetera. So we want to call it high-touch primary care. At which point I said, well, High Touch was the name of the escort agency our governor got caught using last week. And so it rolled out in the states, and I saw some colleagues here from Maine earlier. It rolled out in the 8 states in their pilot as advanced primary care, but it's based on a set of principles that really go back into the pediatric literature to 1967 or 1968. And it's the core concept that was raised in an earlier panel discussion I saw. You know, when you have that one bit of information, when you have that important piece of data that you need to capture, if you don't have a place for that information to flow and be held accountable, it doesn't work. And the whole concept of the medical home is to really create a place where there's a system integrator where actionable information can flow and centralized, and then something unique happens to it, it's held accountable. It's held accountable, and it's held accountable to also empower the patient to be held accountable as well, which is part of the conversation. I was in a National Governors Association meeting not too long ago, and my CEO spoke, and we showed this little video clip that was on NPR, and I'm going to start off the talk with that and then step aside and then come back on the stage. If you could run the Hobbs video, thank you.
Rocked by recession, the city of Hobbs was sorely in need of a source of new jobs. So one day the mayor stood up on his stump and suggested a plan to get them out of this slump.
I've read the reports and seen the predictions from the Bureau of Labor and their statisticians that jobs in the sector of healthcare are rising by thousands per day, with experts surmising this trend in employment can only get bigger. As the nation gets older, it's bound to get sicker. So how can we profit from this demographic? The answer is obvious: hospital traffic. We'll get out-of-towners to come here when they ache with a medical complex, best in the state. Thus, the more good healthcare jobs we'll create.
The city did just what the mayor had envisioned. Tax breaks followed by cutting of ribbons on a medical complex so modern and new it caused wonder in all who walked through it. The top floor was the brain. Below that, the nose. The bottom floor studied the stubbing of toes. Ouch. While the mayor just waited for those tourists to visit, he spied through his spyglass something rising.
What is it?
Just in yonder city, 12 miles up the river, they built up their hospital tower even bigger, with a special addendum, a surgical spire that climbed an additional 50 feet higher. For hearts to be paced, spines to be spaced, kneecaps replaced, brain waves retraced. They even gave complimentary massage to anyone left waiting in the parking garage. It was just so much fancier. It had their spot beat. The mayor was nervous. He smelled his defeat. He had to compete with this terrible spire. But how?
What's this?
He have to acquire the all-organ blast and make younger machine. It had just been invented. Extremely expensive. Did it work? No one knew. It was still being tested. The point was they'd have what the other town lacked, and thus the more patients and jobs they'd attract. The town was in favor, but a man in a suit stood in and said,
"My dear mayor, your plan is a hoot. This arms race you've run with your upriver rival does threaten to dun our financial survival. This medical tourist you seek is a fiction. It doesn't exist. When people are sick, then they go to the place that their doctor suggests. They don't drive around the state to shop for the best. And these wings and these towers you've been able to grow means locals use more. That means more dough that businesses must pay for their workers' insurance. So forgive me, dear mayor. I need more assurance that this competitive fervor that's rattled your saber won't end up quite badly for business and labor."
The mayor just nodded. He'd heard words to consider, but the sound of the pounding of nails from upriver made the mayor conclude.
Well, to heck with the cost. If Hobbs doesn't get these new jobs, we're lost.
And so it resumed, the grand competition. The two rival cities consumed by ambition, the one with its tower, the other its spire, each one expanding its hospital higher, much more than the region would seem to require. Till even the mayor didn't know what to write on the hospital billboard they lit up at night. Could he say his was tallest or just second best? He must climb to the top to reckon a test. But as he climbed to the top to spy that town's spire and find out for certain whose building was higher, just then the clouds parted. He could see the whole nation, and so many cities boosting healthcare occupations. But if all these mayors were fueling the fire, then who would be paying for these towers and spires? And what if this medical boom might inflate the size of the debt of the feds and the state? Well, heck, thought the mayor. Why should he schwitz? That was Washington's problem to fix.
You can go back to the PowerPoint. Thank you. So, as I heard the earlier panel talk about the culture of change and the culture of hospitals advertising their high-end delivery service, I was reminded this morning that I should take my brains to Long Island Jewish as I was going down the road to get on the plane to go to LaGuardia. I do think that buyers are reaching a point where we're really rebelling against that, and we're really beginning to have a conversation that's very different. I know that Jack Cochran was here earlier today, and he and I spent some time in Denmark earlier this year, and we were sitting around the table with the Danes talking about probably the best primary care in the world there in Denmark, probably some of the best integrated care that Kaiser has, and kind of how do you combine that. And one of the Danes that was with the Ministry of Health asked this question that I've been thinking about ever since, and I think it's worth thinking about, and that was, in Arizona, who was the shooter's doctor? Think about that. That's a question that really sums up the journey that we're on. You see, we are moving away from trying to buy an episode of care as a buyer of care towards trying to buy a population that's managed. And if you want to sum up this whole journey of medical home, of accountable care, of this transformation, it's really that. It's really thinking about moving away from buying an episode of care to managing a population and to paying for that management of the population with different dials. I see a couple of my colleagues here from Care First. I was sitting in a big, beautiful lobby, not a lobby, it was a conference room overlooking Baltimore Harbor. And Chat was sitting at the end of the table, the CEO of Care First, and he was talking to the providers in Maryland. And we had on one side of the table most of the comprehensivists, on the other side of the table most of the partialists, right, the specialists. And he was outlining how Maryland, Care First was going to be rewarding medical home and how it was going to be paying to manage the population and how the primary care docs were going to be held accountable for some of the total cost, et cetera. And one of the specialists across the table said, I get that for primary care, but what does it mean to me? And Chet said, what it means to you is if you behave, you'll get the referral. It's a very different world we're moving into, and it's quite an interesting world that we're going to talk about today. So why are we here and what are we doing? This is a fascinating chart. This was in Health Affairs a year ago, and it's one of the two best indicators of how well the delivery system works. You see that we're dead last, and we're dead last at twice the price. This is the years of life lived, 15 years of life lived, what percentage lived for 15 years after age 40. So it eliminates infant mortality, all those kinds of issues, right? And, and you know, we have gotten worse, and we've gotten worse at a much more expensive rate. Why? Because we've been focused on the conversation of high-end rescue care, and we've not been focused on robust prevention in primary care or medical home level care. Now, if you look at that slide and you sort of look right there, you'll see Dubuque, Iowa, right? You'll see South Florida. Huh? So IBM is a buyer of care. When we set up a factory, when we look at where we're going to put our employees, this is the kind of place we look for, and this is where we put our jobs. So it's a development issue for the governors. That video that I showed, the conversation that followed was, you know, you continue down that path, and you can hear the sucking sound. It's your jobs. It's your jobs. This is no longer a benefits issue for employers. This is a cost issue. When my CFO gets into the question, when my CEO gets into the conversation, and he asks the question, you know, where can we put the next facility and have a value proposition, and healthcare is one of the elements in that, it's a whole different conversation. Dubuque, Iowa. 4,000 jobs in Dubuque, Iowa. You know? I mean, we're not going to put them in South Florida, right? We're going to move our jobs out of South Florida. So there are three trends that are driving medical home. The first is cost. You know, you've heard about that. That's global. This is what it looks like to us from a standpoint of a buyer of care. This is, you know, this is not a sustainable model. This can't be sustained. It's the elephant in the room for us. The other trends are equally important, though, and they're data. For the first time, we're going to have data. For the first time, a Care First or a WellPoint are going to be able to project information right down into the primary care practice around total experience and cost. We've never been able to do that before. The last time we tried to do some sort of population management with HMO, we didn't have the data. The third element is that my kids, your kids, are used to interacting in a world in which they don't have to see the whites of the eyes of the folks that they're dealing with. They bank online, they do travel online, they do retail online, and they expect the same thing out of the healthcare delivery system. Where we have a medical home, about 40% of our employees now, about a 40% drop in face-to-face encounters and a huge increase in asynchronous communication, right? They get their labs online, they have emails, questions online. You know, that's the third element that's really driving this. So about 5 years ago, IBM, as a large employer, basically decided that we would look at some fundamental issues around how we wanted to buy our health care. So we did a survey of our employees. We asked them, you know, what do you really want? And they said, oh, we want access, we want convenience, you know, we want a meaningful relationship. And when we looked at the data, we weren't giving them any of those things. You know, we were giving them access to, this is the hospital you should do your brain surgery in. And when we looked under the cover when we began to ask ourselves, where do our employees get their care? What does it mean? What are the differences? We discovered that when our employees had a relationship with a comprehensivist, when they had a primary care doctor that was their source of care, and that was their normal source of care, it cost us 1/3 less money. And in that 15-year window, their mortality was 19% less. Dubuque, Iowa. Places where you have robust base of primary care, and it's likely that our employees will have some adult supervision over their encounters with specialists. Other parts of the country, we will have people with 5 partialists, none of them coordinating care, no conversation, right? I mean, how likely is that to be extremely toxic, when you're being given 5 drugs and no interaction, no integration of care? So we asked the House of Medicine. We went to the House of Medicine and we said, you guys, how can we change the covenant? How can we change this conversation? How can we buy something differently? We brought together into a room with 47 large companies of the Fortune 100. We brought together TRICARE and OPM. We brought together in a room in Washington, and we brought together the 4 primary care societies. And we said to them, could you give us a set of principles upon which we could change the covenant around what we buy? These are them. These are the joint principles of the patient-centered medical home. They're extremely powerful. They're extremely powerful because they're an agreement of all the House of Primary Care around a set of principles that they agree to, that 47 of the Fortune 100 said to the healthcare plans in the room, that you're going to do pilots on this, and those of you who don't, we're going to fire you. We're not going to, none of us of the 47 are going to buy any health care from you next year. So the Blues Association, WellPoint, Aetna, Cigna, right? They were all in the room. They've all been doing pilots ever since, right? We now have a lot of data. It's extremely positive data. It's also really, really powerful because it's now become the standard of care for the DoD, the standard of care for the VA. It's the standard of care for 500 community health centers. It's really begun a huge amount of pickup. It's, by the way, really progressed fairly far down the road in a number of states. I mentioned Care First in Maryland, Blue Cross Blue Shield of Michigan, Rhode Island, Vermont, Maine. There's a huge amount of pickup across many states to this model of care. So it's made a lot of progress. But as a buyer of care, the conversation that we had with our healthcare plans in the last quarter when we began to try to renew our contract was, this is the kind of care we want, and I'll get to that in a bit. Hurry. So, what we're trying to do fundamentally is turn an upside-down triangle right. There is no system in the world that works without a robust base of primary care. We tried it. We experimented with it for 30 years in this country. It's failed us. It's failed us miserably, and we don't want to buy it anymore. It's over. There's no country in the world that has a value proposition when the focus is on rescuing the salmon after they fall over the falls and not preventing them from falling over the falls. It doesn't work. It's failed us. It's why we're dead last at twice the price. So this is some of the data. It's a no-brainer. It's an absolute no-brainer. The data continues to pile in. It's extremely successful. We see a drop. Funny thing about ambulatory sensitive conditions, you can actually treat them in an ambulatory environment. It's doable. We see a drop in hospital days. We see a drop in unnecessary utilization of ERs. We see total cost. Mayo, right? Mayo Clinic, the world-famous Mayo Clinic, did this for their employees. 0 trend line in cost over 4 years. How many of you guys have a 0 trend line in cost, right? So this for us is a no-brainer. I was at a meeting in Albany, New York last week. Geisinger was there. Blue Cross Blue Shield in North Dakota was there talking about some of their results. They have now data going out about 4 years. And then CareMore. And what we've seen in those early pilots, what we've seen is a huge success. And for the senior folks that are in the room today, you know, we saw a 60% drop in the complications of chronic diseases, 60% decrease in amputations for diabetics. I mean, Zsa Zsa Gabor might have a leg to stand on, you guys. I mean, there's other places in the world where, you know, we don't see the catastrophes that we have when you fail to coordinate care. It is unethical. It is immoral. It is unacceptable to deliver an episode of care for a friggin' diabetic. 157 primary care docs in the Adirondacks had that conversation, made that statement to the Commissioner of Health in New York. 13 healthcare plans. They said, you know, we're not going to sell an episode of care anymore. A diabetic needs their care coordinated. You can't ask us to sell you an episode of care. For the first time, you know, in the years that I've been in New York, we have seen an inflow of primary care docs into the Adirondacks and not an outflow. We see a much more satisfied physician population. We see a much more stable delivery model. And we have 157 primary care docs that are NCQA Level 3 certified in the Adirondacks. First place in the country where the physician stood up and said, you know, we're no longer going to practice, we're no longer going to accept payment from a plan to deliver unethical care. So one of the conversations that I was listening to earlier today was the technology. One of the things that we think is really cool is the ability that a solution like Watson, you guys all saw it play the Jeopardy game, but it's really about healthcare. It's being able to digest literally the entire information system of healthcare so that the medical students are no longer the storage units, right? Be able to find that one element and project it to the point of care. And we committed to develop this with WellPoint as our first development episode, and we did so because WellPoint committed to us that they were going to move all of their 13 markets to medical home model of care. Because this doesn't work unless you have a place in the system where the data will flow and then be held accountable. I'm sorry, it ain't going to happen in your cosmetic dermatologist's office. I mean, they're not going to aggregate the care. They're not going to aggregate the data. That's the whole concept of what the pediatricians started writing about in 1967, is a place where data is aggregated. It's the home where the data sits. This could be a Medicare Advantage plan. This could be one of any number of things. But it's a trend line of cost in a medical home practice affiliated with a manufacturer that manufactures gears in Indiana. We're seeing this all over the country. You know, you begin to focus on putting barbed wire around unnecessary services. You begin to focus on better upstream care. You begin to focus on managing a population, and you begin to take cost out. The triple aim is eminently possible to do, but you've got to have that basic infrastructure, that foundation of a place to deliver that from, and the agreed upon place to do that is the medical home, and that's why it's so powerful. So traditional fee-for-service, it rewards the service, whether it's good or bad service. And, you know, we pay for a lot of unnecessary utilization when you reward any amount of service, right? I mean, if Zsa Zsa had gotten the wrong leg amputated, we would have rewarded and paid for that, and then we would have paid for the right leg to be amputated. And by the way, we rewarded the system for both legs to be amputated because both legs being amputated happened to earn a whole lot more money for that system than actually managing her diabetes. Does that make it clear to everybody? So what we're trying to do is put in other dials. I mean, that's if you're going to manage the population, you're going to need other dials to manage the population from. So you want some services, and you want to pay fee-for-service for some things. I mean, I want moles removed in the primary care practice, right? So I'm going to pay fee-for-service to have that happen. I'm going to want to reward that primary care practice for answering my patients' emails. So I want to pay them more if they answer the emails in 20 minutes. I want to reward them more if they see my patient in 2 hours than if they see them in 2 weeks. So I want to put in dials that will pay for those kinds of elements, and that's the conversation we're having all over the country with the various healthcare plans in terms of the RFPs that we're banging up against them. I want to pay fee for satisfaction. I mean, one of the models that I've seen that I like the best really has about a third of the payment in fee for service, again, at the primary care level. About a third for total health, right? So the whole community gets rewarded, and about a third for how well you deliver the services. This is CMS's plan. This is one of many, but this is a really great program. It's called the Comprehensive Primary Care Initiative. I certainly hope that folks like Care First are all over this space and going after it, because it's really going to, for the first time, have CMS carry the weight in some of these practices to help them pay differently. It's going to start off with an average of $20 per member per month to pay for medical home level care as defined on this chart, care that's managed, care that's accessible, a chronic disease plan, patient engagement, and coordination of care. So, I mean, we're going to stop paying only fee for service and begin to pay for these. And then in year 2, 3, and 4, it's going to be a shared saving potential as well as this. This will be in 5 to 7 markets, and the deadline for this, the application deadline, is the 15th of November to say that you're interested, and then the actual application is the 15th of January. And I'm really hoping that all of you will push the plans in your region, because this is really designed to go up against the healthcare plans and ask the healthcare plans to commit in their geographies to delivering this care, where CMS will be paying into those practices differently, therefore helping carry the weight of transformation of those practices to PCMH. Does that make sense to everybody? This is another dial that CMS has put in place. This is called Partnership for Patients. This is an 11% change in payment away from fee-for-services for hospitals to keep patients out of the hospital, to keep them from being readmitted to the hospital. And this is a huge deal for hospitals. There are very few hospitals that can afford on a shift of 11% from CMS and have the margins to afford that without really trying to capture this. Another dial is all over the country we see various members of the insurance industry. This happens to be Blue Cross Blue Shield of Hawaii. And Blue Cross Shield of Hawaii basically said, we're no longer going to give any uplift in fee-for-service. Any uplift you expect to see docs are going to be rewarded for being a medical home, delivering medical home level care, and then eventually for outcomes. When I visit a major medical center or a hospital, I went to one on the East Coast, giant sign out in front of the road that said, we do the best heart surgery in the country. I went into that hospital and I said, you're not going to ever get another job in this community. It ain't going to happen. And they're not. It's unlikely. Because I have the data. They're one of the most expensive places that we can imagine. And I know exactly what that sign says, I said to the CEO. It says that we know where the money is and we're going after it. That's not the sign I want to see as a buyer of care. I want to see a sign that says we do the most comprehensive, the most integrated, the most coordinated care in this community. We do it so well that you're going to need to see you're going to need to have 1/3 less heart surgeries, right? And we have populations, because we have the data, where that's happening and happening today. That's where we're going to move our jobs. We've reached a point where we have some of the best partial care in the world. We have the king of Saudi Arabia come here for his backs. We have the Yakuza from Japan come here for their kidney transplants. You know, it's kind of like the Olympics a few years ago where we had the very best basketball players in the world. We went out, put them on the court, and they got whooped by the Albanians. Remember that? I mean, you know, you have 5 specialists out there, and none of them can pass the ball, none of them can coordinate the ball, none of them can team, none of them integrate. And that's exactly what we face as a buyer of care. You know, we do twice as much heart surgery because we have to, because we fail to do the robust prevention in primary care. Literally, I have populations, literally, that we need to do 1/3 less heart surgery. I have populations today where my adult immunization rates are in the 90th percentile. I have populations where, you know, where every one of my females have their mammograms done. That's where we move our jobs. So the medical home, for us, is the system integrator. It's the place where the quadruple aim or the triple aim can take place. It's the place where data flows in. You have a healing relationship with a primary care provider. They and their team are held accountable for that data. You can't do accountable care without that. I sat and listened to the 10 PGP practices tell me that. You've got to have 2 things. You've got to have the medical home and you've got to have the data. And you've got to have the transparency of the data, integration of both clinical data and claims data. And you've got to have a place to deliver that from. So this is a napkin. It was drawn by Ib Johnson. He came here on a Harkness Fellowship, probably 20 years ago from Denmark. He went back to Denmark, drew this napkin out. And it's the medical home in Denmark, right? It's like the Wharton Business School model that, you know, kind of, you know, when I ask him, you know, where'd you get this from? He said, oh, I got it from America. They've gone from 157 hospitals in 15 years to 21. They've gone from 80% of seniors dying in the hospital to 90% dying at home. They've gone to care that is rated by the patients as the most satisfactory in the world. And some of that is having infrastructure, right, as well. So at home, a patient is offered the opportunity to have digital conferencing, to have remote monitoring, to have other things that are done. And it's very, very patient-centered. I went with one of my employees to pick up their mom at a hospital in Denmark, and it was really funny. We walked into the room, and the doctor said, Mrs. Johnson, are you ready to go home? And, you know, we have all this equipment. We have the whole healthcare system delivered, set up to take care of you at home. And Mrs. Johnson said, no, I want to stay here. And it turns out that 16% of Danes say that. And so I asked the doctor, when is Mrs. Johnson going to go home? And they said, well, whenever she's ready. It was very cool. So this is the kind of care we're talking about. We're talking about superb access to care, 24/7 coverage. We're talking about remote monitoring. We're talking about the ability to interact with email, the ability to really engage. Profound patient engagement. I visited a practice in Florida where the doc there, a pediatrician, has gone from having 1 patient hospitalized a week with asthma to 0 in 4 years. And you watch what happens. It's patient engagement. It's patient empowerment. You know, it's really the ability to engage. Holding patients accountable. Interesting conversation. Absolutely. I completely agree. I listened to that earlier. However, the patients have got to friggin' understand what it is you're telling them. Well, there's this little kiosk called Wellbe that we use. And what we discover is 60% of our patients, who are our patients, right? So they're IBM employees or, you know, reasonably sophisticated. 60% of them don't have a clue what the doctor just told them, let alone holding them accountable, right? I mean, they, by and large, right now, the way the system works is they got their hand on the door. And they're focused on flow-through because that's how they get paid, right? And I'm not blaming them. It's just the hamster wheel that they're on. Clinical information system. At least a registry, right? When we moved to the Hudson Valley, my cat had a registry. You know, got notified of its immunizations, and my wife didn't. We're now in a medical home 5 years later because we've been building that in the Hudson Valley. My wife was notified back in July that her mammogram was due. She got it. And last Tuesday, she had her 3rd chemo, right? And by the way, it was early. and it hadn't spread to her nodes, and it's adjunct rather than palliative, right? Because somebody notified her, asked her, would you ever remember to get that mammogram? She said, probably unlikely. I mean, that's how you save those lives, right? That's what you do. Care is coordinated. Powerful, powerful tool is care coordination. In the Hudson Valley, care coordinator, the nurse, sits right in the practice, hired by 4 healthcare plans, follow-up, follow-through, coordination of care. That's how you result in a 60% decrease in your amputation. It's team-based care. It's extremely powerful. I visited in Dubuque, Iowa, a young doc there, and an 84-year-old nun was the patient I got to visit that day. The nun comes in, and Chris Krasinski, the doc, says, "How's your didgeridoo lessons going?" This is an Australian instrument, which I probably mispronounced. But at any rate, there was a 5-minute conversation about, this Australian instrument, and then the doc says, "You're going to go with the nurse team coordinator, and she's going to help you design a plan for your diabetes for this year that's going to follow up and follow through." I went with the nurse, fantastic plan, better than the doctor could have done because the nurse is probably trained better to do it anyway, but a team, right? It really powerful. I then asked this nun, "What do you think of your doctor?" "Oh, I love my doctor." And the coordinator comes back into the room and says, "The cat Millie," which goes into a little EMR, which of course was going to be the question next time. How's your cat Millie? It's 2 things that you should do for a doc that I want to spend $6 a minute for. That's difficult diagnostic dilemmas and relationships. That's it. The rest of the team should do everything else. And then patient feedback and publicly available information. This is the RFP that the Office of Personnel Management used. This is the RFP we used. This is what we demanded against the healthcare plans. Healthcare plans in the room, they'll know this very well because for 3 weeks, every single day, one of the Fortune 100 companies sent this RFP in every day. Every single day we slammed this up against them. We said, this is what we want to buy. We want to stop buying the garbage you're selling us, and we want to buy this. Right? So this is OPM. That's a $40 billion book of business. That gets people's attention. And when you add that to many of the Fortune 100, that gets everybody's attention. So this is a place under the sun where we've actually seen integration of sick and health care. 1.9 cents out of every sick care dollar goes into a community health team coordinator model of care. And it's very cool. We've seen an 11% drop in trend in our costs there in Vermont. We're the largest employer there. But I visited one of these medical homes there, and the community health care team was coming that day. By the way, their office was right in that medical home to pick up the 4 diabetics who were recently diagnosed, and they were going to take them through a walk of the local grocery store and then begin the hiking on the hiking trail that the community had developed. So they really begin to integrate the health department, the hospital, the community health center. They asked themselves the 3 questions that the community would want to focus on for health. This particular community had expanded their smoking cessation, their obesogenesis program. Very cool. Social media. This is the last element of the 3 trend lines. We're beginning to see a really significant pickup in the way patients encounter their doctor. And patients love meaningful information about themselves. This is Dr. Holly, a wonderful medical home in Texas, and he uses Cognos to mine the data and project specific information about the patient right down to their laboratory results, what it means to them. It's not a rip sheet, and this gets just reinforced and reinforced and reinforced. And I think I have about 5 minutes left, and I want to use a couple of minutes to show a last video. I was just in Hawaii. I visited a medical home there, and I particularly like this because it's exactly what happened to my wife in this clinic. They also tracked her up with their mammogram. But before I do that, this is the cost differential. This is not Dartmouth Atlas data. This is not CMS lives. These are our lives. These are commercial lives. And just like we've seen the Dartmouth Atlas, there's huge variation in cost. Anybody read the Atul Gawande article, Cost Conundrum? Great article, right? If you have, you remember that McAllen, Texas was one of the most expensive places for CMS. It happens to be one of the cheapest places for us. And the reason why is because of Medicare fraud. I mean, how else would you account for shifting? And by the way, Peter Bedetti is my really good friend. He's a head of integrity. It's Medicare fraud. Criminal activity, literally, in McAllen, Texas. With that, could you roll that video? Thank you.
PCMH stands for Patient-Centered Medical Home.
The patient-centered medical home model puts the patient in the driver's seat.
PCMH is keeping the patient at the center of care, and it actually helps us down the road because that patient doesn't get readmitted to the hospital, have to go back to the emergency room. So there's a lot of pluses to it in the long run, looking at the bigger picture.
Not only are we trying to be preventive, we try to give our patients the information that they need so that they can be proactive in their own healthcare.
What I like about it is that we can do our case managing and we can help the patients to help themselves. So we can spend a lot more time teaching.
Having targets and goals in my healthcare has really helped me. It's given me the desire to be a little more active.
As we continue to educate patients and support patients with the things they need, they'll be able to help themselves.
Kaiser has come a long way, making you realize that doing preventive care, it's really very easy.
Through the Patient-Centered Medical Home, we started a program where we call back every patient that was discharged from the hospital or discharged from the emergency room.
My husband has had cancer 3 times, and there were times where he thought he would just not make it. There were times when he would want to give up. As he got the phone calls from the nurses to see how he was doing, it would really build his morale, and that kept him going.
When you see the benefits that it does for the patients, it makes it all worth it. You know, it makes it worthwhile.
PCMH helped validate what we were doing and really put it on paper and made it just a little bit more standard so that everyone's doing it.
Even patients tell me, you know, it's different now. I feel like you guys are doing more. Before it was from the doctor, now it's coming from you.
The numbers are improving. Patients are getting better care.
Now we're doing so much outreach. We make sure that they have their mammograms, their labs, their colorectal screenings. Everything is on point.
And because we're always, mindful about scheduling mammograms, I've had patients come in and, thank me for scheduling a mammogram, and I say, no, it's not me. It's my medical assistant that was doing it.
I was through, I was getting ready to leave, and she came down the hallway, she saw me leaving, and she goes, no, you're not going anywhere. You're not going anywhere until you make an appointment for a mammogram.
Because she was following her standard work of scheduling mammograms for patients, we found out that she had cancer, and it was at a stage that was treatable. And so she's a cancer survivor today.
You can't thank them enough. I mean, what do you do when someone saves your life? It's the God's truth. If she hadn't stopped me that day, and I probably would have been dead by now because it was a very aggressive cancer.
Life is important. To preserve it by screening is powerful.
Compared to, say, a year ago or 2 years ago, my job is a lot more meaningful.
We've become more of an integral part of the healthcare team.
I'm there with the doctor, and I'm not just the medical assistant. I'm his colleague. I work with him. We are the team that care for our patients.
I think there's excitement because we're always looking to do newer and better things for our patients.
HPMG has been leading the way in so many ways, and I'm proud that we're doing so with the PCMH here in Hawaii.
So I went into this particular practice with one of my employees 3 weeks ago, and they were going in to pick up their glasses. We went to the counter, and the administrator there at the counter said, in the optical part, right, said that you can't pick up your glasses. You have to go down to the pharmacy and pick up your prescription for hypertension because we see you haven't picked it up in 3 weeks. Bring it back and show it to me, and then I'll give you the glasses. So, I mean, they literally use every opportunity to really begin to empower and engage the patients around the proper care, right? This is the kind of place, and we see this in many communities, where we literally see 1/3 less necessity to do heart surgery, literally, because somebody's doing the ABCs, right? The aspirin, the blood pressure, the cholesterol. Somebody has the discipline to follow up and to follow through. That's the kind of care we're going to insist on buying. You know, and if you want to sell us episodic, disintegrated, uncoordinated care, we don't want to buy it from you anymore. Thank you very much.
Have time for 1 or 2 questions?
I don't want to keep you from your hors d'oeuvres too long, though.
So it doesn't work, so I'll just scream. So.
The green light is
Hello?
Yes.
Okay, sorry about that. This is God, thank you. No, thank you, Dr. Grundy, that was terrific. So I have a question about integrating behavioral and physical health. So I know, I mean, oftentimes different carriers for the behavioral portion of the behavioral health and a different carrier for the medical portion of it. Is that important to integrate, and how do we do that?
Absolutely. It's so important to integrate mental health, behavioral health into the whole package. We have certainly in our buy, but I visited a number of clinics where this is really integrated. At the core of every chronic disease is behavioral health. I mean, that's the very core of what you're addressing. And to your point, some of the best places I've seen that, the Merlac Clinic in Grand Junction, Clinica Salud in Colorado, I visited a couple of those where they really have profoundly integrated. In the military, the U.S. Army, which is, they're now every service member has a medical home. I visited one in Savannah, Georgia. 8 primary care docs in a practice, and integrated behavioral health, integrated mental health right into that model. Every chronic disease patient has part of their therapy behavioral health. It's really, really important. The PCPCP, the group that I'm the president of, we have a special group led by Fung Kwang. We've done a couple of white papers on that, and also you're welcome to join in. It's entirely free. But there's a very, very detailed conversation about that, but it's extremely important, and thank you for the question. One more, is that?
Good afternoon. Neil Wasserman from Health Center. One of the issues, following up on the previous question, in terms of allowing patients to focus on behavioral health or allowing employees to focus on behavioral health, one approach that we're taking is looking at a more general model of health. That is, we apply the same model for adopting habitual behaviors that apply to chronic disease management and wellness, to financial behavior management, to workplace productivity behaviors, to social engagement behaviors. And one of the reasons is that there's a multiple payoff for the employer to address the ability of employees to adopt these regular behaviors. And there's a benefit to the employee to be able to apply those skills in adopting habitual behaviors that benefit their physical health to these other domains. So there's a kind of synergy in the different health domains. Have you applied that kind of philosophy at IBM? Do you see a value in taking a broader view of behavioral?
Absolutely. It's a culture, really, creating a culture. If you look at my photograph, which is a few years old, I've lost almost 100 pounds since then. And, it's just a culture. And, I think our smoking rate is probably below 3% now. And you just wouldn't see anybody smoking in front of their boss. And I mean, we've not allowed smoking on the campus in 10 years, but I mean, it's just really creating a culture where you talk about ownership, accountability, and it's across the entire range, including health. One of the things that we've been really successful around is ownership of obesity in childhood. And, you know, we reward our employees for going through training around that. And we discover that our employees do better when they're focusing on ownership for their kids than they do for ownership of themselves. But really it's creating that culture, and that's really important. And that's the reason why we were all over that Blueprint for Health in Vermont, was creating a culture in our community. And the reason why we refused to do corporate concierge medical home, i.e. build your own on-site clinic, because we really feel responsible for creating a milieu in our communities where we have a big footprint to do this for our mothers as well as for ourselves, right? Because we know in the long run that it's the center of community health that's going to ultimately affect us. So it's beyond individual behavior, and it's about how you create a culture in your community in which you have a village where our employees, friends, neighbors are likely to be thin and not fat, likely to be non-smokers and not smokers, and that's when you create medical home and that kind of a culture like we're working on in Vermont. I mean, I just think it's that sense of commitment. Yeah, thank you. Now it's on to hors d'oeuvres.
All right, well, that was a fantastic way to end the day. And I want to thank all of you for your attention throughout the day and all the sessions that we had. I hope you learned a great deal and were spurred with at least a couple ideas that you can bring back home in your own work. I know I have. I also think maybe that for the day we got a real picture of diametrically opposed forces that are going on in healthcare. I mean, we heard a lot about some fantastic work that are really solving the problems and dealing with the major issues that we're all trying to grapple with, and it's actually working. But in some ways, it's also emerging, and it's going to really take time to get hold. If you think about what we heard from our friends in ONC and HHS, some of that innovation work is just beginning and really requires a lot more attention and a lot more funding. Just as some of the new care models, and ACO is a brand new model for all practical purposes. And if you go back home and talk to people about what's an accountable care organization, you're going to get very different answers depending on the part of the country you're in and who you're asking. What Dr. Grundy was talking about, patient-centered medical home, and some of the institutions that I've been with have been fortunate enough to have really thriving ones. There's hundreds and hundreds of pilots that have been going on, so it's a lot more proven. So that's really on the hopeful, positive side of a lot of terrific signs and projects and initiatives that are really moving us in the right direction. On the other side, what I mentioned earlier this morning are all of the financial pressures that our organizations are under, which are likely going to be compounded pretty soon by a financial tsunami that's going to come out of the budget deficit talks that are happening in D.C. I mean, something's going to happen, and it's not going to be good. And how those two match up, we have to let play out. But it's certainly not converging in that way. And then another tension that really struck me, listening to Dr. Grundy, talking about any new care model needs a robust base of primary care in order to be effective. There is literature all over the place that says that. And I mentioned this morning, we already in this country have a shortage of primary care physicians. And everything that's happening is making that worse. So how are those two supposed to come together? I mean, for somebody where I am at Leahy Clinic, we don't have a shortage because certain parts of the country have enough physicians. In Massachusetts, which have mandatory insurance for everybody, there are parts of the state where it's really hard if you can't at all get a primary care physician. So Massachusetts isn't out of the woods with that at all, but in other parts of the country it's more acute. So if we know that certain models require physician competencies in various areas such as primary care, we as a nation really aren't doing anything to foster that. In fact, what we're doing is going to exacerbate that in a major way. So I think all we can do at this point is just keep our eyes open and note that there are these polar opposite forces that are going in different directions. And we just need to be flexible and see how they're going to play out. And the best we can do is what we're hearing through the sessions throughout the day is really do the best that we can in our part of the healthcare world to make our institutions or our part of the work better and stronger, solve the problems in our area, and hope that we all connect up at some point as the whole national picture tries to sort itself out, because at some point it really does, but hopefully not in a way that undercuts all the progress that we're hearing is being made. The other suggestion I would have is we just go next door and have a couple of cocktails and forget the whole thing. So, which is what I'm going to invite you to do, and I also just want to thank the sponsor for our cocktail hour, which is Philips. And again, I really want to thank all of you for your active attention throughout the day. And there's one more day to go, and I hope you have a wonderful evening and a great day tomorrow.
Good clinical quality equals great economic vitality.
Sentara Healthcare operates more than 100 caregiving sites, including 9 acute care hospitals and numerous outpatient care campuses, assisted living and nursing centers, and advanced imaging centers. Bert Reese is Sentara's CIO.
The challenges that I face are probably not the ones that you would expect as a CIO. What I worry about is how do I take technology and use it to be able to provide better health care with less resources so that we reduce the cost but increase the quality of health care. We do that with our vendor partners. We try to bring in innovative technologies from the best providers of technology in the world, and we integrate them into solution sets that we think create unique value.
As one of Sentara's key partners, Philips offers solutions that enable information to be acquired, analyzed, interpreted, and presented when and where it's needed in the appropriate format.
We have chosen Philips imaging systems for our cath labs for all the different hospitals. We have a hybrid OR now, and the hybrid OR allows for a continuum of cardiac care where a cardiologist delivers a certain level of service, cardiac surgeon comes in and does another level of service, and we integrate digital information from fluoroscopy and from previous heart catheterization, CT angiography, MRI, echocardiography, all together in one room, side by side, to be able to look at those things simultaneously. It's wonderful. We got the TraceMaster system, which allows us to do EKGs any place across the system, one system. It immediately is delivered to our electronic medical records.
Philips solution set, one of the things we like about it is the interoperability between the solutions that they provide us and the ability for them to interoperate with our electronic medical record. That combination creates real, genuine value.
Sentara was the first in the United States to implement an eICU, a Philips telehealth solution that provides remote monitoring of ICU patients. The eICU provides a critical care safety net that helps health systems leverage scarce resources and improve the quality of care. It provides an added level of vigilance on top of quality ICU care while addressing the shortage of intensivists, the physician specialists who care for ICU patients. Sentara's eICU nets out impressive results.
We staff with an intensivist, 2 registered nurses, and 1 administrative associate. We are currently monitoring at 5 hospitals, 103 beds, and 11 units of Sentara.
During the course of the journey, we saw great improvements in clinical quality. We saw that we saved a patient's life every week, that the length of stay in the ICUs dropped. Shorter length of stay in the ICU means better outcomes and shorter expense because the ICU is a very expensive place for a patient to be. So at the end of the journey, we concluded that good clinical quality equals great economic vitality. And so when we started electronic medical record journey, we reflected back to those days with Philips and VisiQ and said basically, let's go for the clinical quality. maybe a good analogy is an orchestra. And our goal is to choreograph all these pieces into one unique integrated solution set, so that as you are a provider of care or you're a patient, it all looks seamless to you. It all sounds like music to you. And our electronic medical record experience now generates about $40 million a year worth of new revenue to us and less expenses. And we're happy to have Philips as a partner to help us do that.
Centera also implemented the electronic medical record in a unique way. Ambulances are equipped with Philips 12-lead ECG monitoring, so they can share vital information to a hospital's emergency department while in transit. And that information becomes part of the permanent medical record.
The ability to be able to recognize a heart attack in the field and alert the hospital makes the hospital aware. They can get their equipment and their personnel ready to receive us as soon as we get in the door.
Philips enables decision-making not just at the point of care, but at the point of need. The revolutionary IntelliVue MX800 is a monitor and an information system all rolled into one. Caregivers can make informed decisions instantly by viewing everything from lab results and diagnostic images to PC applications on the same screen that shows the patient's vital signs.
I think dynamic data, retrospective data, and predictive data, those three to me make up clinical decision support. What that means is that you're using the information that's provided by your monitoring devices, your clinical devices, you're mixing it with other information, data, and algorithms, and you're recommending to the caregivers, to the administrators, different plans of action. So the clinical decision support is as a result of seeing all these different combinations of data that's then translated into information that then the caregiver, the manager, takes into action. That to me is a broader view of clinical decision support.
Of course, we add value by not only incorporating clinical decision support, but also by considering the needs of patients. For instance, Philips recently introduced Cableless Patient, monitoring devices that untether patients so they can enjoy greater mobility, which may aid in their recovery. The devices send data to a central monitoring station. This network can be integrated seamlessly with the hospital's existing wired network infrastructure, helping to leverage technology investments. Physicians can even monitor patients remotely with telemonitoring devices that can monitor everything from a patient's vital signs and weight to blood pressure and glucose levels.
As the boomers age in, we need to be able to have leverage more patients with less healthcare workers. And the way you're going to do that is with technology. And the classic example is home care and home care monitoring with the Philips devices, where we can take one nurse in a command center and she can monitor a lot of patients at home. You're going to have to do that with primary care and the other chronic care diseases like congestive heart failure and things like that. So finding technologies that leverage the healthcare worker, I think is a big deal.
Customers rely on Philips as a partner, providing the innovations that enable efficient communication between patients, clinicians, everyone involved in delivering quality health care. And those partnerships have enabled performance excellence. Centera is a nationally recognized IT leader and award winner. They were recently voted the #1 integrated delivery system in the United States by Modern Healthcare magazine.
Centera is really hard-nosed business operators. From the business side of it, we're very tough, very disciplined. Philips got to where it is because it earned it. It earned it in the early days because they gave us a good solution set. They kept to their word, and their solution set provided value. And they brought us more and more solution sets that we thought created value. And so the trick is to take all these solution sets and then integrate them and bring them together. And I got to tell you, Philips has been a wonderful partner.